I think we have a very important topic of fever or pyrexia of unknown origin. As we know that fever's majority is settled down in 7 to 10 days time, and not many other fevers, it takes some investigation that you are most often able to reach a diagnosis and the problem is sorted out. But fever can be really nasty. You do everything and the patient tells you, "Aaj fir aa gaya hoga." And there you really need efforts, a proper way, when to call it a fever of unknown origin, whether it is 3 weeks, 2 weeks, or extensive investigation in a week's time. The speaker would enlighten us on this. One should be careful that not many, although there are 200 causes of fever, but some of the fevers which we came across, which were challenging, at times it was DVT, at times it was giant cell arthritis. Recently, we investigated a patient for 1 month and it turned out to be adult onset Still's disease. And with macrophage activation syndrome, the ferritin levels were 10,000 plus. This patient responded to steroids. At times it is scrub typhus, at times it is leptospira, or it could be polymyalgia rheumatica, giant cell arthritis. One patient we investigated thoroughly and we were at sea that what is the cause. And finally patient was complaining of, as and when he will get fever, there was pain in the body. On wound scan we found he had mets from prostate, and then it was a patient sent to me by a urologist. He realized that he had done a prostatectomy, PURP 10 years back. So there were mets from prostate. So it can really be challenging. At times, effusions not getting better. You do a tap, say exudate, and you find, especially in females, it is a lupus, systemic lupus. So I get ANA done in all female patients of pleural disease. I think with this small introduction, Dr. Amina Mobashir, she is a consultant, respiratory, sleep and critical care medicine at Max Sake. She will be delivering her talk on Pyrexia of Amina.
Let's hear it for Dr. Amina.
Thank you very much, sir, for the kind introduction. It is an absolute privilege to be speaking in front of such an esteemed gathering this evening. Good evening, and beginning with a small update on Pyrexia of unknown origin, because while preparing for this I realized there's a lot to be spoken on and we have a little less time. So beginning with the normal human body temperature, of course, we all know it is 98.6 degrees Fahrenheit. After analyzing more than 1 million axillary temperatures from about 25,000 patients, Wonderlic identified 37 degrees Celsius as the mean temperature in healthy adults. And temperature readings more than 38 were deemed as suspicious or probably febrile. So for healthy individuals 18 to 40 years of age, the mean oral temperature is 98.2 plus minus 0.7 degree Fahrenheit. So of course there's variation that occurs from morning to evening. So in the morning a temperature of 98.9 would be considered the normal, whereas in the evening as much as 99.9 is considered to be normal, which is why most of us tell our patients that only take a paracetamol if your temperature rises above 100 degrees Fahrenheit. So the normal rectal temperatures are generally 0.7 degrees Fahrenheit higher than oral readings. This is helpful in pediatric patients. Tympanic membrane values are lower as compared to the oral temperatures. So how does fever occur? Basically, it is a combination of release of interleukin 1 and interleukin 6 along with TNF release that leads to a rise in body temperature. If you look at the pathogenesis in brief, there is of course the T lymphocytes, or in case of antigen antibody complexes as seen in autoimmune disorders of vasculitis. Then there is bacteria and bacterial products, viruses, crystals, which ultimately attack the mononuclear phagocyte and leads to release of endogenous pyrogens, which, like we discussed, are interleukins and tumor necrosis factor, leading to release of prostaglandin E, which causes heat generation as well as heat conservation at the same time, leading to fever. So what is PUO? The classical definition of pyrexia of unknown origin is a fever higher than 38.3 degrees Celsius, which is 101 degrees Fahrenheit on several occasions. The duration of the illness has to be more than 3 weeks, and there should be no diagnosis made after 1 week of inpatient investigation. So if we classify PUO, basically broadly there are 4 types of pyrexias of unknown origin. The classic PUO, which I just discussed, then there's nosocomial pyrexia of unknown origin, in which the temperature is more than 38.3. The patient has been hospitalized for more than 24 hours, but no fever or incubating organism on admission, and there's been an evaluation of at least 3 days. Classical examples of this would be Clostridium difficile enterocolitis, drug-induced pulmonary embolism, septic thrombophlebitis, very common, sinusitis. I'll discuss the immune deficient and HIV-associated PUOs in the next slides. So basically the definitions here are slightly different. In case of an immunodeficient or a neutropenic patient, PUO is defined as recurrent fever in a patient whose absolute neutrophil count is less than 500 per millimeter cube and who has been assessed for 3 days without establishing an etiology for the fever. In case of HIV-associated PUO, the definition is somebody having a recurrent fever over a 4-week period in an outpatient setting or a 3-day period in a hospitalized setting with HIV infection. So the most common etiologies of pyrexias of unknown origin would be infectious, malignant or neoplastic, rheumatic or inflammatory, and miscellaneous disorders. If we see the global picture, the non-infectious inflammatory disorders actually account for the highest percentage of fever-causing etiologies, and in this NIID group, polymyalgia rheumatica is the most common. The other causes would be infection in about 23% patients, malignancy about 10.7%, and others or unknown in 23.1%. Looking at the Indian perspective, we have 4 or rather 5 large studies which have published the causes of pyrexia of unknown origin in India, and as we can see, TB is our most common enemy in this case. However, there's a study from Srinagar in which 44% patients were found to have brucellosis and salmonellosis. And also another study from Wardha, which is central India, reported that the major cause of unexplained fever, as much as 46%, was enteric fever, and 5% cases were due to malaria, all caused by Plasmodium falciparum. So, primarily, broadly in India, TB does remain a very common cause of pyrexia of unknown origin. Quickly going through the etiology, so in bacterial you can have sinusitis, mastoiditis, dental abscesses, endocarditis, TB, abscesses, UTI, osteomyelitis, septic phlebitis, mycotic aneurysm, endocarditis, IV catheter infections, central line associated infections, and infected prosthesis. In parasites, the most common is malaria, toxoplasma, schistosomiasis, amoebiasis, hydatid cyst. In fungal infections, we can have candidemia, cryptococcosis, aspergillosis, mucormycosis, and viruses like CMV, EBV, and HIV, of course, are causes of fever. Malignancy, any malignancy more or less can present as a low-grade or even a high-grade fever in patients. Then we were just discussing the non-infectious causes like connective tissue diseases. Dr. Mangla sir just discussed adult onset Still's disease, which is a common cause of fever. Then granulomatous diseases like Crohn's and sarcoidosis, vasculitis syndromes like giant cell arteritis, polymyalgia rheumatica, again very common, and temporal arteritis, for which you might need to do a temporal artery biopsy for diagnosis. So other causes could be factitious fever, thromboembolic disease, thyroiditis, and drug-induced. A long list of drugs, but the common ones that actually used particularly in the hospital settings are carbapenems, cephalosporins, erythromycin, isoniazid, minocyclines, even penicillins and rifampicins can cause fever. So whenever a patient comes to you with a 3 weeks or 4 weeks history of fever, it is very important to communicate a few things to them to begin with. So first is of course that the investigation can be time consuming and frustrating. Many diagnostic tests may be necessary because a common complaint is that हम 2 हफ्ते से test ही कराए जा रहे हैं and we still don't have a diagnosis. And the test may even be repeated several times, and the fever itself is really harmful. So we need to get to the cause of it rather than sort of putting a band-aid on the wound. So coming to the history and types of fever, of course you have to look at the degree, the type, periodicity, frequency, toxicity, pattern, response to antipyretics, etc. Broadly, 3 types of fever: continuous, which is there throughout the day, does not vary by more than 1 degree Celsius, classically lobar pneumonia as we see in our practice. Remittent fever is there throughout the day, but there's a variation, however it doesn't touch the baseline. Intermittent fever is present only for a few hours in a day. Twice daily fever spikes, so double quotidian fever is seen in malaria or visceral leishmaniasis. 2 fever peaks per week, or the camelback fever curve is seen in leptospirosis, brucellosis very commonly, or rat bite fever. So, a classification of the recurrent fevers is relapsing fever. So again, days of fever followed by an afebrile period of several days and then a relapse into additional days of fever, usually after 14 to 21 days. Then there's a Pell-Epstein fever, in which the fever would last for 1 to 2 weeks, followed by 1 to 2 weeks of an afebrile period, very classical of a non-Hodgkin's lymphoma. And then there's periodic fever that recurs over months or years. So the subtle differentiating features in all of these fevers, of course, if there's night sweats and weight loss, you would obviously think of tuberculosis or other infectious cause. In case of arthralgias, myalgias, fatigue, as a history along with fever, you would think of autoimmune disorders. Again, for malignancy, there can be history of night sweats and weight loss, and are more likely to have pain and lack of appetite as well. Then specific history, pets, wild animals for cat scratch disease, brucellosis, travel, region-specific diseases, then transfusions, a history of transfusion can lead to a diagnosis of malaria, hepatitis B, C, and even HIV. If there is an in situ catheter in a patient in the ICU, of course, the first thing that you think of is a catheter-related bloodstream infection. And if there's a prosthesis, you can have osteomyelitis. In case of immunosuppression, you think of the wide spectrum of opportunistic infections that are there. And then localizing symptoms would be nocturia consistent with prostatitis. Other physical signs that can guide us to a diagnosis: relative bradycardia, conventionally thought to be very common in typhoid or enteric fever. In terms of skin changes like an erythematous rash or other rashes can be seen in tropical fevers particularly. S-char can be found in scrub typhus. So a lot of times in a lot of patients with a history of travel to areas with forest and plants, when they've come to us with fevers with no other diagnosis, we've actually in some of them found S-chars, and then their scrub typhus IgMs have come positive subsequently. They respond very well to treatment. Classical splinter hemorrhages or clubbing that would be seen in infective endocarditis. Murmurs again in infective endocarditis. In the lungs you can have Krebs, pleural rub in case of pleuritis. Then if there is sternal tenderness, bone marrow involvement disorders can be a possibility. If there is involvement of the vertebral column or joints, you have to look for tenderness for osteomyelitis and joint infections. Again, a lot of physical examination to be done in a patient who presents to us with fever. Look at the oral cavity, look at oral ulcers that can suggest Behçet's disease, even SLE, ears, mastoids, lymph nodes in the neck, thyroid enlargement, and ultrasound neck is something which we very regularly do in our patients with PUO. Then eye examination to look for uveitis, rod spots, retinitis, optic neuritis. In fact, just today we have done an EBUS of a patient who had presented with fever and loss of vision, admitted under neurology team, and they could not find any reason in the MRI brain. So they did a serum ACE level which was 82, and then we did a CT scan. There were large mediastinal lymph nodes which turned out to be granulomatous on the EBUS. So other than that, retinal hemorrhages you could see in pre-leukemia, retinal vascular exudation, and vasculitis. Now lymphadenopathy, of course, if we examine, a lot of information is provided by the kind of lymph node that we see. in tuberculosis, the lymph node is mostly firm, matted, cervical adenitis is seen, then lymphadenopathy can be there in castrash disease, mostly diffuse. It could be biogenic. Inguinal lymph nodes can be seen in syphilis, herpes infections, and generalized again in viral illnesses, lymphomas. Sarcoidosis again in Kikuchi's disease, again a common etiology in young patients with lymphadenitis and fever. Then you look for hepatosplenomegaly on examination, multiple causes. If you look at the syndromic approach for PUO, there's abdominal pain, splenomegaly, relative bradycardia, you make a diagnosis of a working diagnosis of enteric and then investigate the patient further. If there's PK clubbing, like discussed, infective endocarditis can be there. Pulmonary TB, Dr. Nangia is going to be discussing in detail with us subsequently. And if there is diffuse large lymphadenopathy with hepatosplenomegaly, always consider leukemia and lymphoma in such patients. So basically, it's not a very good quality slide. So basically, if you have a diagnosis of fever of unknown origin, you look for positive findings on physical examination, and if it leads us to some sort of a working diagnosis, then we can investigate on those lines. So minimal initial diagnostic workup for FUO would be CBC plus differentials, ESR, CRP, peripheral smear for thick and thin film, LFT, RFT, thyroid profile, Montroox, quantiferon gold, urine routine and cultures, 3 paired blood cultures, chest radiography and ultrasound of abdomen, just a basic workup. Now coming to the utility of CBC, there can be a whole lot of WBC abnormalities, leukocytosis, leukopenia, relative lymphocytosis and relative lymphopenia, each with its own set of differential diagnosis. Then monocytosis would be seen in malignant lymphomas and can also be seen in miliary TB, histoplasmosis, brucellosis, visceral leishmaniasis. Then atypical lymphocytes again can be infectious, brucella, malignant. Eosinophilia is commonly seen in lymphomas, can also be seen in histoplasmosis, can also be seen in autoimmune disorders. Basophilia again seen in pre-leukemia, AML, acute leukemias, lymphomas. Then there is a whole lot of RBC abnormalities again with a lot of differentials for each one of them. The further diagnostic test would include a ferritin level. So like sir was just mentioning, ferritin level is also an acute phase reactant. So a very, very high ferritin level can mean that there is an inflammatory pathology ongoing in the body, primarily inflammatory. Then Beal Felix test can be done, Vidal of course. Serum protein electrophoresis again very, very important in patients in whom there is unexplained fever, you are not getting to any diagnosis, all the other tests, the scans, the CTs, ultrasounds are all coming out to be normal. May have a reversal of EG ratio on the LFT, so serum protein electrophoresis is very helpful. In fact, just last week there was a patient who was admitted with us in SmartMax who had come with a long-standing history of fever for almost a month, being treated as E. coli infection in the urine and then had received appropriate antibiotics but continued to have fever and we found nothing. And then subsequently, we did a serum protein electrophoresis. It came out to be positive, then a bone marrow biopsy confirmed multiple myeloma, and is now on treatment for that. You could do multiple serology testing like hepatitis, HIV, CMV, EBV, Q fever for leptospirus, Cryptopus, Bartonella, Brucella, Toxoplasma. Autoimmune profile, very, very important in the workup of any patient who presents with long-standing fever, particularly with arthralgias and joint pain history. Then radiology, one would like to go ahead with CCT, thorax and abdomen, echo for any vegetations, Doppler of the legs for DVT, MRI of aortic arch and great vessels of the neck if vasculitis is suspected. Now the radionuclear tests that can be done in a patient in whom you are not getting any answers are gallium-67 and indium-111 labeled leukocyte scanning, which are highly sensitive by virtue of including the whole body. However, neither of these studies can pinpoint the diagnosis. They can only show a collection of leukocytes somewhere. The overall yield of these tests may be higher than with the CT or ultrasound since the latter tests focus on only a few parts of the body. Another very, very important diagnostic tool, which we again use when we are sort of pushed against the wall and we're not getting a diagnosis in a patient with long-standing fever is the PET scan. So the idea here is that the FDG is taken up by inflammatory and cancer cells because of their high rate of glucolysis. So even if a patient has infection or inflammation, that area will light up on a PET scan, and it does not necessarily mean that there is a malignancy only. And we do it very regularly in patients in whom we are not getting a diagnosis despite all the conventional CT scans and ultrasounds. A hybrid of CT and PET scan has a higher diagnostic yield with a sensitivity of ranging from 56 to 100% and a specificity of 75 to 81%. The 18FF FDG has a better uptake and is cleared more rapidly than the older modalities. However, it is costly, not widely available. Then coming to the biopsies, of course, if we do know that there is some abnormality somewhere, based on the scans that we have conducted, we go ahead with a tissue biopsy as indicated, whether it is a lymph node, liver, temporal artery or bone marrow. For the liver biopsy, the diagnostic yield is between 14 and 17%, can reveal granulomatous hepatitis. Again, a patient just last month admitted with us, EBUS had been done and he had been at another center very thoroughly worked up, and just a liver biopsy gave us the diagnosis of necrotizing granulomatous disease. Lymph node biopsy is most useful in diagnosing lymphoma, infectious diseases and granulomatous diseases. Another very important thing which I was just discussing with Dr. Pankul also for one of our common patients is the naproxen test, non-specific although, but in patients with fever more than 7 days treated with naproxen, infectious fever may or may not show a response, but if it is fever because of a neoplastic condition, it shows a prompt lysis of fever within 24 hours. Then coming to the therapeutic trial of antibiotics or steroids, so while it is tempting in the effort to do something, but it rarely establishes a diagnosis, and in some cases it can even reduce the diagnostic yield of the blood culture. So it can pose a bigger problem if you're just trying to treat something with an antibiotic and you don't know what the cause is. The appropriate duration of a therapeutic trial is unclear, and infections such as endocarditis or PID can take as much as 1 week for fever to abate even with appropriate therapy. Antimicrobial agents may suppress but not cure many infectious processes, and they have effects on other infections than the ones to which the therapy is directed. For example, if rifampicin is used in a therapeutic trial for tuberculosis, it may suppress staphylococcal osteomyelitis as well, and diminish the ability to detect difficult to isolate organisms causing endocarditis. Fluoroquinolones, as recommended in the Western guidelines to be used for community acquired pneumonia, may mask tuberculosis, which is a major problem in India. So, indications for empiric therapy are limited when there is suspected culture-negative endocarditis. Neutropenia, of course, you will not wait and take a chance. Hemodynamic instability, you would want to start. And empirical antibiotics, suspected active tuberculosis, suspected temporal arteritis with the risk of vision loss. Clinical emergencies for patient referral to tertiary care unit. So, management of patients presenting with fever of unknown origin is a challenge for any emergency department physician. Fever might resolve spontaneously in some cases, and other serious bacterial infections might develop. Those younger than 5 years with unexplained fever presented more frequently to the ED and accounted for the highest proportion of admissions. So conditions with requirement for urgent investigation and management would be infective endocarditis, can be life-threatening, disseminated tuberculosis, CNS tuberculosis, and giant cell arteritis. Another important cause of prolonged fevers post the pandemic is a long COVID or the post-acute sequelae of COVID-19. It presents as a complex and multifaceted illness affecting a significant proportion of individuals who have recovered or are recovering from COVID-19. And a lot of studies have been done on this, and the most common symptoms that were found were chronic fatigue and fever. Long-standing low-grade fever for months unexplained after somebody having tested positive for COVID. Then other associated symptoms could be anxiety, chronic fatigue, postural orthostatic tachycardia syndrome. And these symptoms in certain patients have seemed to be persisting for years together. The risk factors are number of symptoms during acute infection, viral load, genetic factor, vaccination status, pre-existing autoimmune and health conditions, gender, age and severity of the initial infection. There can be a reactivation of viruses also post-COVID, including EBV and HHV6. They have been found in patients with long COVID. A recent preprint has reported that EBV reactivation is associated with fatigue and neurocognitive dysfunction also in patients with long COVID. Now the management of such patients is of course multidisciplinary. Primarily it involves rehabilitation, physiotherapy and symptomatic treatment. For a person who just has fever, low-grade fever, post-COVID and there's no other cause that can be found, just a symptomatic treatment would suffice. Other treatments for different symptoms and symptoms of long COVID, for a post-exertional malaise could be placing. For the tachycardia syndrome, one would give beta blockers, metoprolol, pyridostigmine, even non-pharmacological therapies like increasing the salt and fluid intake. Then IVIG we've used in some of the patients with immune dysfunction and fever. One could also use coenzyme Q, then if there's abdominal clotting, anticoagulants. And viral persistence and antivirals, Paxlovid now has a role. So quickly a couple of clinical scenarios. So the first question is, all of the following evaluations should be included in the initial workup of classic fever of unknown origin except a CBC, chest radiograph and cultures of blood and urine, ESR and gallium scan. So the answer would be gallium scan because this is what the first line of diagnostic investigations that one would do. A 32-year-old woman with HIV/AIDS with a CD4 count of 25 presents for evaluation of PUO. CT scan of head reveals two ring-enhancing lesions, one in the basal ganglia and the other in parietal lobe. All of the following are in the differential diagnosis except aspergillosis, lymphoma, nocardia, toxoplasmosis can all present as a ring-enhancing lesion, but progressive multifocal leukoencephalopathy will not. Then a 25-year-old asymptomatic heterosexual woman recently diagnosed with HIV and a CD4 count of 250 and a viral load of 85,000 copies is at higher risk than the general population for which of the following? Cryptococcosis, NTM, PJP, toxoplasmosis or tuberculosis. So with a CD4 count of 250, which is less than 300, this woman would be at a high risk of developing tuberculosis. So quickly going through the pathogens that may be causing different diseases. So if you have a CD4 count of more than 200, strep pneumonia, H. influenzae, staph, pseudomonas, legionella, nocardia, TB, limited to lungs is common. In patients with a CD4 count less than 200, PJP is very, very common, and in those with less than 100 cells per millimeter cube, CMV, NTM, aspergillosis, histoplasmosis and coccidioidomycosis along with cryptococcosis and toxoplasmosis also can be seen. A 45 years male, low-grade fever for 1 month, nausea, vomiting, loss, decrease in weight, low BP, low sodium and high potassium. What could be the possible cause? So a lot of electrolyte imbalances also along with the low-grade fever. So there would be adrenal involvement, again seen in patients with tuberculosis also. 46-year-old female, low-grade fever for 5 weeks, bilateral hilar lymphadenopathy, routine lab test normal, Monto's positive, serum is 62. What would be the next logical step? So the next logical step would be bronchoscopy, EVAS, FNAC and transbronchial biopsy because we do have bilateral hilar lymphadenopathy. Serum ACE is also high. So we need to differentiate between sarcoidosis and tuberculosis. A positive Monto's alone would not be sufficient for a diagnosis of TB in India. A 27 years female, fever for 5 weeks off and on, enlarged right cervical lymph node, FNAC showed necrosis. possible diagnosis. Young female with a necrotic lymph node. Kikuchi's disease, very common in females. Kikuchi's disease is a possible etiology. So to summarize, PUO is defined as a fever of 38.3 degrees Celsius or greater for at least 3 weeks with no identified cause. In India, the most common causes are infections, TB being the most common. A thorough history and physical examination are essential, needless to say. If they fail, then further investigations, including imaging studies and serological tests, are carried out. A definitive diagnosis can be reached in as many as 85 to 90% of the patients if we investigate thoroughly. And empirical therapy is discouraged except in certain special situations. Thank you very much.
Thank you, Dr. Amina. We will have question answer session after the end of second talk. Next talk is by Dr. Vivek Nangia on difficult to diagnose TB. Dr. Vivek Nangia is a principal consultant of Director, Pulmonology, Critical Care and Sleep Medicine at Max Saket Hospital, Super Specialty Hospital. He has organized a number of teaching programs, PNP course, arranged a lot of conferences on chest infections. I think we all know him, Dr. Vivek Nangia.
Thank you, Pulmonology sir, for introducing me, and thank you, Dr. Chauhan, for inviting us to this 892nd event of yours, which is like really a landmark. I think 1,000 is not very far from here now, and it's always a pleasure to be here with all of you. You almost seem like an extended family for us, and we really feel at home whenever we are here. Of course, always prepared for the questions that are going to come at the end of it, but we enjoy that too right now, really. So, Dr. Chauhan at the beginning itself laid down the grounds for us, and Dr. Amina, while talking about PUO, laid down the grounds further, extended it, that it's very important to reach a diagnosis before starting a treatment. In India, for some reason, we tend to be a little, I would say, tight-fisted when it comes to doing investigations with the patients. We tend to rely more on our clinical judgments. I don't think there's any harm in doing that, but the clinical judgment must be backed by the relevant lab investigations which are supportive and diagnostic of the diagnosis that you have reached. Otherwise, starting every patient right here and there, especially when in today's era there are such high-end investigations available, not reaching a definite diagnosis, like in this young boy, 26-year-old boy, who we lost within 8 days of his illness. 7 days of fever, and I think another 5 or 6 days that he was shuttling between hospitals, and we lost him. So probably had he reached and stuck to one center in time and not started on empirical treatment, he might just have still been alive today. But tuberculosis, as I said, is very common in our country. There are more than 10 million people globally who are suffering with TB. 1.3 million deaths annually because of tuberculosis annually. And in our country, there have been some 24.2 lakh cases, marking an increase of 30% from 2021. So there is an increase in TB. Yet, I am saying that we should not be treating our patients empirically, and I'll show you why. We need to have a definite diagnosis for each and every patient, even when you're suspecting it to be, strongly suspecting it to be tuberculosis. So when would you really suspect it to be tuberculosis? When there's a patient who's come with cough for 2 weeks or more, fever for 2 weeks or more, there's a significant weight loss, there could be hemoptysis, a non-resolving pneumonia on a chest X-ray, or on a CT scan, or any other abnormality on a chest X-ray. That is when you start thinking that yes, this patient could be tuberculosis. But at the same time, every shadow that you see on the chest X-ray is not tuberculosis, is the message that I want you to remember. In which group of patients? Those who have been basically in contact with a pseudopositive patient, people living with HIV infection, diabetics, malnourished, cancer patients, those on immunosuppressants and steroids, primarily because they'll be more prone to developing tuberculosis as an opportunistic infection. So this is the group of patients where you would be suspecting TB. Let me start with the first case. A chronic smoker, 52-year-old male, cough, phlegm, low-grade fever, loss of weight, appetite, increased cramps in the right infraclavicular area. CBC is normal, ESR is 118, BON2 positive, sputum AB negative, HIV negative, ESR 118. And this is the radiological picture. What is the first diagnosis? Very good. You would expect this to be tuberculosis. But in this kind of a situation, Dr. Amina was talking about empirical trial of antibiotics. It's safe to give an empirical trial of antibiotic. But please remember, we do not use fluoroquinolones, levoflox, ciproflox, oflox, none of these antibiotics for anything to do with respiratory infection, because if this is tuberculosis, it will get masked completely. The fluoroquinolones as well as linezolid are very good antitubercular drugs, so we keep them as reserve drugs only for multi-drug resistant tuberculosis and not for usual tuberculosis or for even the usual infections. So this is two group of antibiotics that we banned from our ICU, from our unit. We don't use it unless there is enough of a justification to be using it. Then of course, there is no role of inaccurate or inconsistent diagnostic tests like the serology, the quantiferon golds, the various in-house or validated PCR tests and BCG tests. There is no role of IGRA in diagnosis of tuberculosis. The typical features on a chest X-ray would be focal infiltration, bilateral disease, lobar or segmental consolidations, cavitations, effusion, enlargement of lymph nodes, small fibronodular lesions which could be miliary mottling, pleural effusion. These would all be typical features. Then on the CT scan, this is a typical picture of tuberculosis where there would be small nodular infiltrates, stream bud appearance. But again, none of them are classical of tuberculosis. They could happen in a plethora of other indications as well. So what would you do? Would you start this patient with ADT or wait for some further workup? So you suspected this patient to be having tuberculosis, sputum is negative, MAL2 strongly positive. What would be your next step? Sorry? I couldn't hear you, sorry. Further workup, right. So further workup is very, very essential. Further workup could be in the form of a induced sputum sample. Ask the patient to cough up sputum in the morning after taking 3% normal size nebulization and send that for investigation. And when you're sending it for investigation, it's very important to send the sample for sputum AFB, 2 samples, 1 gene expert and 1 AFB culture. Sputum should not be only AFB smear, it should be AFB smear, gene expert, AFB culture. All 3 in 1 sample goes stat. If still the sputum is negative, bronchoscopy should be the most reasonable next option. So there are various studies which have shown, this was a Korean study, nationwide has shown that in patients with sputum AFB negative, when they performed a bronchoscopy, they could reach a diagnosis, conclusive diagnosis in another 50% of those patients. So bronchoscopy would be performed basically in patients who are not able to reach a diagnosis, where there are infiltrates which are strongly suggestive of tuberculosis. After bronchoscopy, you can even consider sending a post-bronch sputum sample, because that is the time when the patient is coughing and bring up phlegm from within. So that is a sample that you can send. Another sample that you can send is a tissue biopsy. So when you take AFB culture, when you're doing a bronchoscopy, you also take a transbronchial biopsy and you send the biopsy also for culture. Just this morning, I saw a patient for whom we'd done a bronchoscopy and biopsy about 2 weeks back. Barn smear consistently negative, AFB culture consistently negative on the smear, but on the transbronchial biopsy today, the patient has shown AFB culture positive. After 2 weeks, the culture has turned out to be positive. When you do a biopsy will typically show you Langerhans cells and central necrosis, cases, necrosis, epithelioid, granulomas, and all of that. But what is important is that these are the various tools that you can do. As I emphasized in the beginning itself, we need to send a Ziehl-Neelsen stain, that is the smear positive smear stain. Then you need to do a gene expert. Once it is positive, you would want to do a drug sensitivity also to be able to see that what all is this bacteria sensitive to or resistant to. This is typically how an AFB would appear on a smear examination. But we need to remember that microscopy is more specific and has less inter and intra-reader variability than the X-ray. So microscopy of the sputum is more reliable than a chest X-ray that you've seen. And of course, Gene Expert is a remarkable test which can detect even up to 10 bacilli per ml of the sputum sample on these new Gene Expert Plus kits that we have in our hospital. So Gene Expert is something that you should be sending. It's basically a molecular genetic test which gives you a lot of information, not only the information whether it's positive or negative, but also if it is rifampicin sensitive or not. Because one rifampicin sensitivity report can change the complete diagnosis and complete line of management. Once you've done that, your patient is sputum AFB positive, Gene Expert positive, rifampicin sensitive. What do you do next? Do you start the patient on anticoagulant treatment? Well, yes, you start the patient on anticoagulant treatment, but at the same time, you must send the sample for XDR panel also. XDR panel is done on the same sample which is lying with the lab. Once the patient comes back to you with a report saying it's rifampicin sensitive, it's positive, Gene Expert is positive, so you send the patient back to the lab that please ask them to do an XDR sample as well. In the XDR, they will look for resistance towards INH, ethionamide, ethambutol, fluoroquinolones, amikacin. So these 4 drugs they would look at, not ethambutol, sorry, but the aminoglycosides, fluoroquinolones, ethionamides, and INH. So 4 drugs would also be looked at. Out of these, the first line drug INH is very, very essential. Again, if the patient is rifampicin sensitive and INH resistant, then the treatment line will be totally different. If the patient is rifampicin resistant and INH sensitive, then you can still consider INH as an option. A high dose INH can still be tried in those patients. Otherwise, if it is rifampicin resistant and INH resistant, then the patient has to be treated as an MDR TB. So that is the role of XDR TB test that you must get done in your patient who is Gene Expert positive, rifampicin sensitive, or even rifampicin resistant. Even then you should be doing it. Then you also have the line probe assays, the Haynes line probe assay 1, line probe assay 2. Line probe assay 1 looks at the first line drugs, the HRZD, and 2 looks at the second line drugs. Again, PCR based tests. So in our case, we were positive for enterocollosis, rifampicin sensitive. We sent in the XDR panel. XDR panel was also positive for all 4. Sorry, it was resistant to INH and sensitive to the rest. So that is the importance of the XDR panel that you must do. So this will completely change the line of treatment for this patient. And on the transbronchial biopsy, necrotizing melanomas were present and violent tissue AB cultures were negative. Coming on to the second case for the evening, a 36-year-old female low-grade fever for 2 months, mild dry cough, CBC is normal, ESR 35, MON2 negative. Anything that you see on the X-ray?
Cardiomegaly, sir?
Yeah, absolutely.
Hyper-elegant lungs bilaterally, sir?
Perfect. If you see, there is slight prominence of the aortic knuckle here on the left side. So probably there are some mediastinal lymph nodes here. We got the CD done and there were small mediastinal lymph nodes. But again, even when it is come to the diagnosis of extrapulmonary tuberculosis, these are mediastinal lymph nodes, so typically they are extraparenchymal. So when it's lymph node tuberculosis, again you need to rely on some kind of diagnostic tools. If you saw one of the previous cases also that Dr. Amina had shown, bilateral hilar lymphadenopathy, ACE levels elevated, EBUS should be done in those patients, and I'll just come to that. So here in these cases, you will rely on 2 things. One is the histopathology and the other is the microbiology. So both the things will need to correlate with each other and only then can you start the treatment, not if only one is positive and the other is not. Unless it is the microbiology which is positive, while the histopathology may be sometimes misleading, because if it is only showing granulomas, that could even happen in sarcoidosis. That could even happen in a malignancy. Sarcoidosis or sarcoidosation or malignancy is also a known entity to happen. Therefore, when we do an endobronchial ultrasound guided biopsy or even a lymph node FNACN biopsy, This is something that I'm sure all of you must be getting done for your patients. You must remember, when you're sending the sample, you send it for FNAC or a biopsy, but also send the FNAC for AB smear, AB culture, gene expert. Same for the tissue. Whatever you're taking it out, whenever you suspect tuberculosis, please do not rely only on the histopathology or cytopathology, but also send the sample for AB smear, gene expert, AB culture. All three together in one sample. It may be a little extra cost, but it will save the patient a lifetime of a moderation, I can assure you that. So in a patient like this, you would want to do an endobronchial ultrasound. Endobronchial ultrasound is a bronchoscopic procedure that you do in these patients who have mediastinal lymph nodes, where you introduce the scope inside. The scope has a small little ultrasound at its tip, which will help you identify where the mediastinal glands are, and then based on that, you puncture the gland. It's a very high precision job, and take the material from it and send it out for investigations. They are practically now, over the years, we've learned to access practically every possible lymph node in the mediastinum, barring one or two stations which cannot be accessed. They also can be accessed using the same endobronchial scope, using it through the esophagus, and you can still get the right material. The diagnostic yield is 68 to 87%, and sensitivity is 45 to 95% of the endobronchial ultrasound used through the esophagus. Transvascular approach can also be taken in selected patients, but you use only a very fine needle in that situation. The patient, but what we've done is, we've gone beyond the FNAC now, even in the lymph nodes. So what we do is, what is called the cryobiopsy from the lymph nodes. See, there's always a limitation of the tissue. The pathologists are always hungry for more tissue, more tissue, more tissue. So while we do ROSE, that is rapid on-site evaluation of all our samples, that means when you're doing an EBUS, you're taking the material from the lymph node, sending it to the lab for investigation while the procedure is still on. So they see it under the microscope and tell you that what is it that you're expecting. If they give you a definite diagnosis, very good. If they don't, then we keep puncturing it till they give us a definite diagnosis as to what it is. This is called ROSE, rapid on-site evaluation. Well, some pulmonologists have specialized and doing it themselves also with the microscope inside the bronchoscopy lab itself. But we focus only on the procedure right now. So what we do now is, besides the ultrasound guided FNAC, we also do a cryobiopsy from the lymph node inside. So from the same passage where we inserted the needle, we insert a very fine cryobiopsy probe into that lymph node and take a biopsy out, which was unknown till about 6 months or 1 year back. But we are amongst the first centers in the city to be doing it, to be taking out biopsies from inside the lymph node, which gives you better yield, better diagnostic material, and better chances of reaching a diagnosis. As you can see, this is the catheter which is inserted and just pulled out with a tissue. So there's a lot that one can do now to reach a definite diagnosis even with your mediastinal lymph nodes. This is definitely less invasive than a mediastinoscopy or a VATS-guided procedure, which of course would be much more costly and also more invasive, requiring incisions, requiring ports to be created. This can just give you a diagnosis in 35 to 40 minutes of the procedure that it is done. So coming back to our patient, Bal AB smear negative, gene expert negative, AB culture negative at 6 weeks. The EBUS ROSE only showed us reactive lymph nodes. The TBNA showed occasional granulomas. The gene expert was negative, but the AB culture that came was positive at 3 weeks. That was luckily sensitive to all, so we could start the patient on treatment. Patient had already started on treatment based on these necrotizing granulomas that we got on the cryobiopsy. So while our FNAC failed to give us an answer, but cryobiopsy did show us that the necrotizing granulomas were present. So you were relatively confident that yes, this is tuberculosis and nothing else. And finally the culture came after 3 weeks. By then the patient had already received 2.5 weeks of HT. So that only reinforced our diagnosis and confirmed that we were on the right track. Coming on to the third case for the evening. 60-year-old male diabetic, right-sided chest pain for 1 month, dry cough and shortness of breath, and an absent air entry in the right base. As you can see on the X-ray, there is a massive right-sided pleural effusion. A diagnostic pleural aspiration was done, exudative in nature. ADA was only 22. ADA has recently become a marker for tuberculosis. So any patient who receives it has an ADA of more than 45, 60, you would consider it like a blanket, it is tuberculosis, but again that is not the case. There are various other situations also where ADA may just be falsely elevated. So just based on low ADA and high ADA, you can't really be sure that this is tuberculosis. While you do have a relative degree of confidence that yes, if it is an exudative, lymphocytic, high ADA, you are still safe in starting the patient on antitubercular treatment. But what happens in many of these patients who have massive effusions, when you start them on ATT without withdrawing all the fluid, they tend to develop fibrothorax over a period of time. 60-70% of the fluid is absorbed, but 20-30% of the fluid that remains inside results in fibrothorax. So why leave a problem behind if you can actually evacuate the entire fluid? And I'll tell you how we can do that. Especially in a situation where it's a dilemma, it's a low ADA fluid, exudative lymphocytic, you're still thinking tuberculosis, non-tuberculosis, what do you do? A simple procedure which is called medical thoracoscopy. This is a procedure which is done by the bedside of the patient, can be done by the bedside of the patient. Of course, we do it in our bronchoscopy suite. The costs are very, very low. It can be done as a day care or a maximum 3 to 4 days of hospitalization. All you have to do is just puncture from one side, from the side where the pleural effusion is, under local anesthesia and mild sedation. Insert a trocar cannula, put the scope inside, the medical thoracoscope. You're able to visualize the entire pleural cavity after evacuating the fluid and take biopsies from there. The advantage is that the biopsies are under vision, so you know exactly from where you're taking the biopsy, where the lesions are, and sometimes, in fact, when you see what it is, you just know on the spot that what the diagnosis is. So when you combine a needle biopsy with effusion culture, the chances of reaching a diagnosis are 61%, whereas with medical thoracoscopy, the chances of reaching a diagnosis are 99 to 100% when you do it. This is one such patient, as you can see, classical case of tuberculosis, small nodules, thin fibrinous adhesions, effusion has been taken out. When you get this kind of a tissue and you pick up this tissue and send it for cultures, the chance of yielding AB is much higher on these tissues rather than the fluid that we send for culture. There are thin loculations which can be broken also. So such patients, as I was talking about fibrothorax, the advantage of doing medical thoracoscopy in these patients with massive effusions is to break these adhesions and take out all the fluid and then expedite the recovery of the patient. I'm sure all of you would appreciate the fact that if the source of infection is still there in the body, then it will take much longer for the body to heal rather than removing all the sources and then continuing the antitubercular treatment. So if you get a SARCO-like pleuritis, grayish-white blanket, thin fibrinous adhesions, loculated fluid as I just showed, this can't be anything else but tuberculosis. This is like an on-the-spot diagnosis that you can make and start the patient on ATT. So many times we've seen patients, when we send the pleural biopsy for histopathology and culture, AB turning out to be positive on the tissue rather than on the fluid as many cases. And then, as an advancement in our procedures, even in the pleural biopsies, we've started using cryoprobe. Cryoprobe basically has the advantage that it freezes the tissue and then brings out a much larger chunk than you would normally get. So you get a larger chunk, you get a more definite diagnosis, and you're more confident in what you're doing. This is one of the patients where we had taken the biopsy first from this nodule. The pleural biopsy being performed from the nodule of the patient. And usually you would get a very small tissue when you do it. Of course, this was a soft kind of a nodule from which we could get a good tissue. But I think this is the part. This is a cryoprobe which has been infused into the pleural cavity, the tissue has been frozen, and then look at the size of the tissue which has come out. Large, chunky material, which gives you so much of satisfaction that yes, the chance of reaching a diagnosis are 100% when you do this. So in this patient, we got a pleural tissue gene expert positive, rifampicin sensitive, we got the XDR gene expert done, INH resistant, fluoroquinolone resistant in this case. So when you get an INH resistant case, what is the drug option that you use? You would use rifampicin, pyrazinamide, ethambutol, and a fluoroquinolone. But in this case, when you got the XDR done, even the levofloxacin was resistant. So we couldn't use that. So what I'm trying to emphasize is the importance of reaching a tissue diagnosis and a microbiological diagnosis both. Microbiological diagnosis will help you decide what treatment option to choose for your patient. So to summarize it all, this is how a patient with presumptive tuberculosis be approached. You check the sputum, the X-ray, the sputum smear, look for gene expert. If positive, then do an XDR. If negative, then do a induced sample. If negative, then do a bronchoscopy, biopsy, send the tissue. Send as many samples as you can to reach a diagnosis. In this age and era, again I'm reiterating, when there's such advanced diagnostic modalities available to us, we should not refrain from at least making an attempt to reach a definite diagnosis. With those words, I'd like to thank you all for inviting me and giving me this opportunity to speak.
Thank you, Dr. Nangia. Exhaustively dealing with diagnosis of PUO and treatment part also. Let's move on to the first talk of Pyrexia of unknown origin. What questions? First, I would like to ask Dr. Amina that you dealt with the Pyrexia of unknown origin in a very exhaustive, more than a lot of causes. But usually, in majority of cases with 1 or 2 weeks of fever, you do a baseline test, all cultures and all. Suppose fever does not settle down in 2 weeks. You have done CT chest, CT abdomen. What is your next line? When do you investigate the collagen disorder? After 2 weeks of fever, how do you approach? Once you have done all cultures, you done all the baseline tests, CT chest, CT abdomen, the patient is still hurt.
Thank you, sir. So like you yourself mentioned in the question, after 2 weeks of the first baseline investigations, if the patient still remains febrile, then we move on to the level 2 of investigations. We check the autoimmune profile, particularly if there is some history of arthralgias and even a subtle history of any symptoms or signs suggestive of an autoimmune disease. Then also, if we don't get an answer, then we go on to doing cerebral protein electrophoresis and even PET cancer. If the patient is still symptomatic with significant fever and we're not able to pinpoint as to what is happening, a PET scan in this situation has in almost all the cases given us a definitive answer as far as our clinical practice is concerned.
Doctor, I would just like to give a small hint. A good clinical examination is very important. At times, in my experience, I have found that if you palpate the nodes in the neck, sometimes you get a node, a small node. At times it may be a malignant node, or at times it will be a tubercular. Give time, just don't do like this. And this is very helpful. Repeated examination of the patient, asking history again, maybe at times repeating cultures, and then as per the history going on to the next set of tests. It does help. Like our patient of adult onset Still's disease, one of our physicians, we admitted this patient in our hospital, and one of our physicians, he said, "Yeah, I 1-2 years देखता हूँ," so he straight away did a ferritin, and the levels were rather too high. And our oncologist also agreed, and we treated this patient. So similarly, I think maybe sometimes you find TB, sometimes you find node, you do a biopsy. At times you think it is TB, it turns out to be malignant. So I think one has to repeatedly examine.
Doctor, the definition of PUO is fever more than 101, but the fever is above 100. What is the rationale? Where do we replace the person having between 100 and 101? What is the rationale for that? You will be missing the people who are having temperature between 100 and 101. It's 100. No, 100. Definition of
No, it is 101 only. The issue is
It is 101 only, so Harrison also puts safety.
the only thing is that what would
Normal temperature is from 96 to 99.9.
So this is what the definition is. We can't challenge the definition which has been said.
definition rationale क्या है?
This is basically based on the number of 1 million, more than 1 million tests they have performed and monitored the temperatures, only then they have come to this conclusion. But the issue is, I agree with you. So what happens is that in these patients you have to see whether this temperature of 100 is associated with malaise or not malaise. Women even in their mid-cycle period could be running a 99-100 temperature. So if it is associated with malaise, then it becomes significant. If it is associated with other constitutional symptoms, night sweats, weight loss, loss of appetite, fatigue, exhaustion, then it becomes symptomatic. Then it becomes important to investigate further. Otherwise, you can ignore it for some time. We've had so many patients who've been investigated for 3 months, 4 months of pyrexia persisting, not found even a single cause. And this lady that I'm talking about has had fever 2 years back, also similar lasting 3 years, and then it's done. But she doesn't have anything else but just a warm feeling by the evening. So in such a patient, you can ignore it. But if it is associated with constitutional symptoms, then it needs to be taken seriously. Right.
Hello.
Sure.
When we are doing LPG CT, sir, then we can, it is mostly used for PET scan, this is used for just malignancy. But it can be also used for inflammatory vasculitis and fever of infective nature. So how we can distinguish whether this case is of the malignancy or this case is of the fever or any inflammatory cause or vasculitis? Please validate upon it.
So two things, sir. First, on the basis of the PET scan itself, the FDG avidity. So in case of an inflammation or an infection, the lesion would be less FDG avid as compared to a malignant lesion, which would be highly FDG avid, a higher SUV max of more than about 8 or 9. And secondly, once you have localized that place where there is an infection, oblique inflammation, oblique malignancy, you can always biopsy from that particular place to get a definitive diagnosis. So that's how we differentiate.
So we just had a recently, just discharged the patient this morning only. Admitted with us first, has been to 3 other hospitals of West Delhi. Then came to us, got admitted with a right-sided mass, the right lower lobe mass. So we did his bronchoscopy, it was a middle lobe mass basically, completely occluding the middle lobe bronchus also. We did his bronchoscopy, 2 transbronchial biopsies, BAL, everything negative, nothing coming to a conclusion. We kept telling him we need to do a CD biopsy. Initially he was reluctant, but when the transbronchial biopsy was also negative, then he agreed to it. And we put a needle into the transbronchial CD biopsy, and that turned out to be positive for TB. So gene expert positive, Fabricin sensitive, XDR negative, XDR sensitive, and the granulomatous necrotizing granulomas on biopsy. So we just started over 82 today and discharged. So basically on the CT scan, we were quite confident this is malignancy and nothing else.
Dr. Vivek.
So,
Hydroxyl deaminase 1, sir, it is increased in pleural feeder, but it is also in inflammatory condition, then rheumatoid arthritis and malignancy also. So what are the levels and how we can differentiate this?
So there are no specific levels that have been specified for these other conditions. So we consider 45 as the cutoff, but the higher it is, the larger the chances that it will be tubercular. But even in empyema, it could be strong, very highly elevated. So again, you have to take the entire picture in totality. It has to be a holistic approach and not just one marker that you're taking.
Because it comes from T lymphocytes.
Absolutely.
One question for Dr. Vivek and one question for Dr. Amina. Dr. Vivek, I'll give you a case scenario. 29-year-old had a problem of high fever going on for about nearly 6 weeks. They did the entire workup, everything, and it didn't work out. I mean, everything was negative. But on the abdominal ultrasound, the lymph nodes were quite enlarged, and they just thought, let's go further ahead. And there was another opinion taken, and the chest X-ray showed nothing. The CT chest showed an artifact in the right apex, which was suggestive of a tubercular patch. And after that, 6 months of ATT was given, 4 plus 3, not the usual 4 plus 2, but 4 plus 3. And the patient recovered. And LFTs were not arranged. And the fever broke in 12 days or 13 days. The patient is me. 2005. I'm talking of myself. Maybe I got the tuberculosis when I was a senior resident, maybe 20 years ago, in Monarasa, wherever I was at that time. But after that, this came up much later, and this worked. The person who treated me was Dr. Senior Guleria, not Radhik's father. So I just wanted to let you know that purely on clinical judgment, he treated me at that time. It's many years ago, almost 20 years ago.
Yeah, sure. So as I said,
So now things have changed. We have diagnosis, we have biopsies, we have but it worked. It worked.
why should you take a chance, especially in this era of medical legal complications? Why should you wait for somebody to respond to a treatment?
Today.
Okay, so again, listen to this. Dr. Chauhan narrated that case, which is very illustrative of another fact, that if this child had not developed, just look at it this way, that if this child had not developed this urticarial rash following the antiviral treatment, he would not have gone anywhere else. He would have just continued with the ATT and continued to bleed, continued to have hemoptysis and die of hemoptysis earlier than even vasculitis would have been dying.
As a pediatric gastroenterologist today, I will look at evidence.
That's what I'm saying.
So that was a different time. So what I'm trying to share with you is that things are like
Thank you, Dr. Sarath, for your insight. Sir, I have a question both to Dr. Amina and to Dr. Vivek. Dr. Amina, you presented with many positive. Can we have some decorum, please? And I want to ask each and every one of you to ask questions now. We had a wonderful CME. Kindly ask some questions so that the speakers go away with the idea that we are serious listeners. At least decorum is the least that I demand of you. You elucidated many causes of pyrexia. Just on the statistical basis, and you work in a tertiary care center, man, what percentage of your cases of total PUO still turn out to be tuberculosis? An honest answer on that.
So majority of them do turn out to be tuberculosis, sir. And we also see a very significant proportion of autoimmune disorders and inflammatory diseases. I wouldn't say that most of them are TB. So I would say there's a healthy balance, maybe about 40% tuberculosis, another 30 to 40% of inflammatory disorders as well.
Inflammatory, multiple myeloma.
Multiple myeloma.
Still's disease. We've had 3 patients with Still's disease with us. Adult onset Still's disease, basically with pleural effusion only. So,
since Dr. Vivek Nangia's talk was on approach to a patient of undiagnosed tuberculosis, first I would like to go back to our moderator, sir, Dr. P K Mangla, sir. He would remember a patient I had referred to him who had come with PUO. We can classically call it PUO. You would remember that patient, sir. I referred him to you in Mulchar. This patient had been admitted in Max Hospital, Shalimar Bagh. Practically everything had been done. At one point in time, he gave us an opportunity to diagnose him when he had a massive pulmonary effusion, tagged to dryness, but nothing came out of it. This patient continued to have fever for 2.5 months. After that, no diagnosis. He came to me from Bagpat and I referred that case to sir and I gave him a background कि सर ये बिल्कुल एकदम नाउम्मीद होके आया है, an employee of Delhi Police, an ex-employee of Delhi Police. Sir saw him, made a diagnosis. It was, I would say, presumptive diagnosis. We didn't have any clear-cut guidelines, and sir put him on some treatment. Patient is there for trial. Sir, I would like to know your experience for the benefit of everybody.
You know, medicine is not absolute science. There is an art to it also. Very easy. 2 weeks fever, 3 weeks fever, 2 months fever. Every day, patient is admitted. You go and they say, "Aaj bhi aa gaya bukhar." You know, we have done everything. We repeated all the tests. I wanted to do a pleural biopsy, but there was no effusion. So we decided, ultimately getting frustrated, to start him on ATT. And you know, with ATT he developed nausea and all. Then we had put him on drugs like lanazolate and ATT. They were kind of ATT drugs, and his fever vanished. With single injection, his fever vanished because he had fever for 2 months. We gave him ATT for 6 months, and his fever never came. And till today, it's more than a year, he is fine. So at times, you know, when we were studying, doing our respiratory medicine, Proctor's book did write, although there was no CT scans or ultrasounds, it did say that no patient of fever should be allowed to die without an ATT trial. This was a line written in Proctor's book. But that doesn't hold, that does hold true. But now we have CT scan, we have PET scan, we have different EBUS, we have biopsy. We so try to prove because it gives you confidence. Because drugs are not that simple. Every patient will develop some problems with the drug. Somebody will have nausea, rash. But if you have a positive diagnosis, you are more confident in continuing these medicines. So I did not have a definitive positive diagnosis for TB, but since he responded to ATT drugs, I did continue for 6 months, and I told the patient the reason for which I am continuing the drugs.
Thank you, sir. Sir,
One common cause that we've also seen in patients with PUO is drug-induced fever. You know, they start with a fever, maybe a viral illness, and then keep getting series of antibiotics receiving, one after the other, courses, fever not settling. You get a thorough investigation done, you find no cause, just stop everything for 2-3 days and see. A low-grade fever will never kill a patient, please remember that always. Low-grade fever, when you look for a cause, is always very painstaking. It's considered to be actually looking for a needle in a stack of hay. So, when you look for the cause of PUO, a low-grade fever. So therefore, never be in a rush, take your time, explain to the patient that this will take time, but this will not kill you for sure. It will keep irritating you, irking you, but will not harm your life. And we'll get to the diagnosis sooner or later.
say your patient in which you had practically made a diagnosis, but the diagnosis was clinched by EBUS, and you had already put him on ATT.
After the necrotizing granulomas was seen.
After the necrotizing granulomas was seen. If you had not done an EBUS, and if AFP culture had not turned out to be positive, the patient would have been alright. Anyway, you had put him on only, except for the fact that he was INS resistant.
INS resistant.
So you changed INS to what, sir?
Levofloxacin.
Levofloxacin. Okay, right. Sir, I want to know that today, if everything is alright and we made a clear-cut diagnosis of tuberculosis, I am asking you to revise a very simple guideline for all of us. What is our principal management of tuberculosis when we start rifampicin sensitive patient?
So when you have a rifampicin sensitive patient, the standard regime that is recommended is 2 months of intensive phase and 4 months of continuation phase. The intensive phase comprises 4 drugs, rifampicin, INH, ethambutol, pyrazinamide, in standard dosages. So I only use Accurate 4 as the brand name just for convenience sake, because it has to be according to the weight band. Then how much is the weight and how many number of tablets that you need to give with it. So first 2 months is the 4 drugs, next 4 months is 3 drugs, rifampicin, INH, ethambutol. Only pyrazinamide is withdrawn. Please remember, only pyrazinamide is withdrawn. 3 drugs are still continued for another 4 months. And because why I'm emphasizing on this is that we still see that patients in whom the ethambutol has also been withdrawn, which was actually changed, I think, way back in 2016 sometime, I guess. Yeah. Around that time back. So it's been like 8 years now, and still people are continuing to follow that 4+2 regime instead of 4+3 regime.
Sir, you mentioned a lot of diagnostic tools, and Dr. Amina also alluded to those diagnostic tools. One grey area of diagnosing PUO and tuberculosis, undiagnosed tuberculosis, is the urogenital tuberculosis. Sir, we still do not have a very, I would say, gold standard tool for diagnosing, let's say, renal tuberculosis. Sir, what is your approach to renal tuberculosis, or you refer them to urologists?
So even for renal tuberculosis, gene expert will not be a standard test when it comes to urinary sample. Even for pleural sample, gene expert is not a standardized tool yet. You would only rely on pleural fluid when you are testing. You would only rely on the cytological and the biochemical picture, and then decide based on ADA, exudative, lymphocytic, or not. Gene expert chances are very low because it's not a standardized test for pleural fluid. Similarly, for the urine, it is not a standardized test, so you only have to look for the urine AFB smear and AFB culture and then reach a diagnosis. Otherwise, it will have to be a cystoscopically taken biopsy from the urinary bladder, or from the kidney biopsy if you are suspecting for some perirenal abscess. So those are the only ways of reaching a diagnosis when it comes to urogenital. In females, it is even more complex because what happens is that these ladies suffering with primary infertility undergo DNC. In DNC, the gynecologist does not send the tissue for histopathology, but would just send the smear for some random PAM proteins, which is absolutely absurd as far as a test for the diagnosis of tuberculosis is concerned. Plus, also remember the gene expert will also pick up the dead bacilli, which could be just colonizers in the urogenital passage. So that would again not be diagnostic of tuberculosis when you're taking it from the urogenital tract, especially in women. Therefore, it has to be corroborated with the hysteroscopic findings of convoluted tubules, strictures there, with histopathological findings of granulomas there, necrotizing granulomas in the uterine myometrial tissue. Only then can you reach a definite diagnosis of tuberculosis in these patients.
Sir, my last question. How far are urinary cultures positive or reliable for AFB?
So that is the only tool that you have, unfortunately. Any patient with recurrent UTI, sterile pyuria present but culture negative, you should suspect for tuberculosis, and sometimes they even ask you to send a 24-hour sample for AFB cultures. So that also can be considered.
Thank you, sir. I would like to go to Dr. JPS. Sir, you have a question? Anybody in the back before I go to Dr. Tulsi? Yes. Dr. Sarat Gopalan will discuss on later. Dr. Arya, sir.
Hello. So how often you come across tuberculosis of pericardial effusion?
So against the pericardial effusion, you will have to aspirate the fluid and then test it. Long back, I had a patient with pericardio-pleural fluid. I mean, if you're saying the incidence would be not as common, but again, any patient with unexplained pericardial effusion, that will again have to be kept high as a suspicion. Aspirating pericardial fluid, especially in a patient with tamponade, is not so difficult. The cardiologists routinely do that now. So you take the fluid out, test it. Pericardial biopsy, we usually don't perform as much because that is very invasive then. There are non-invasive ways also of getting the biopsy done, but our cardiologists are usually not happy. So just based on the pericardial fluid, biochemical, cytochemical analysis, we reach a diagnosis and treatment.
I still remember in 82, patient came to me with fever of unknown origin. In spite of all the investigation, I couldn't reach at any point. I referred that patient to All India Institute of Medical Sciences. They even did thorough echotomy to take out the pericardial fluid and do the aversion of the pericardium also. And they started the treatment. I'm talking about 1982.
Sir, at that time, pericardectomy was a routine thing. And also when you are suspecting constrictive pericarditis and you want to prevent that, then also you want to strip the pericardium off or create a mini window there so that the heart continues to pump properly. Otherwise, if the patient goes into constrictive pericarditis and goes on shrinking, then it will the blood pressure would never sustain.
That's not that easy. That's only because of the patient has gone to the aims only. They go to that much extent. Looking at the patient age and being a female and doing it for what me.
Sure, sir.
Yeah, good.
It's not that easy.
Sir, I have to ask a small question. You have already given a very big talk on tuberculosis, PUO. Sir, you have told that quinolone should not be used as a second line drug. You know, we are using lots.
No, sir. Let me correct you before this goes on. I did not say do not use quinolone as second line drug.
Yes.
I said quinolones are very effective second line drugs. So we reserve them only for MDR TB patients and not use it in any other clinical scenario.
Sir,
Like for chlamydia acquired infections,
Sir,
UTIs.
It is right. But we have to know resistance. MDR is very difficult for us because you have to go for a lot of investigations. Why not to start a quinolone to get better results?
No, sir.
No,
This is something that I would not agree with.
Just let me clarify.
Multiple drug resistance.
Just a minute, sir, just a minute. I think what Dr. P K Gupta is trying to ask and what Dr. Nangia answered are two different answers and questions. No, let me tell you. Dr. Nangia said that if you are suspecting tuberculosis, do not use quinolone as a first line medication for any indication of fever, whether it is UTI or it is a routine chest infection.
No.
Try and avoid it.
No, hold on, sir. So please, you are correct.
Please clarify. Please clarify.
For any clinical condition, there are enough alternative antibiotics available to you. Why should you use fluoroquinolones? Tell me one situation where it's mandatory to give you give the patient only a fluoroquinolone and no other antibiotic.
There is none.
Tell me one.
Sir, typhoid is
Typhoid and cefixime is a very good drug to be used.
Azithromycin, ceftriaxone, ceftriaxone.
So why use a drug which is right now being used as a part of your MDR TB program? Considering in India, drug-resistant TB is also on the rise. You would want to reserve these drugs.
Because it will mask tuberculosis.
And also cause drug resistance further. If the patient is harboring a TB bacteria, even if it is latent, that would develop drug resistance tomorrow when it emerges.
Dr. J.P. Sudsi, sir.
So fluoroquinolones and linezolid, two drugs we completely stay away from unless it's a proven MDR TB patient. That is the only situation where we use these drugs now. Because they're very good substitutes to linezolid also available and very good substitutes to fluoroquinolones also available.
So after those wonderful questions from my colleagues, I had some very simple questions, ma'am, to you first. So finally, the definition of PUO or PUO is settled. Temperature 101 and above for at least 21 days without any definite etiology. After a thorough clinical evaluation, that includes 3 inpatients and 2 outpatient investigations in immunocompetent patients. So this is the true definition of PUO. So let's talk about the 4 groups of patients we have: infective, non-infective inflammatory diseases, neoplastic, and miscellaneous. When you talk about miscellaneous, what would they be? Would they be about subacute thyroiditis? Would they be about colitis and also about drug-induced? So these would be the miscellaneous. And talking about infective, bacteria, viral and fungi probably constitute about 17 to 35% of the patients, and non-infective inflammatory diseases, basically autoimmune diseases, would constitute about 24 to 36%. So let's dwell a little about the lung inflammatory markers which we have today. We are talking about the CRP, the PCT and the ESR. Which is more sensitive, which is really a prognostic marker for inflammatory lung diseases. Would you say PCT, especially if you have a bacterial etiology?
In case of
Talk us about the 3 biomarkers.
right, sir. So PCT could be more useful in case of an infectious
Bacterial.
etiology of Pyrexia.
In viral, probably it's low.
Yeah, yes, sir. So in that case, in viral fever,
The viral etiology, it's low.
so CRP would be a better modality. Also for inflammatory disorders, CRP would be a better modality to look for the level of inflammation in the body. So PCT primarily bacterial infections is.
So when we are talking about these two, especially the CRP and the PCT, you know, the half-life of CRP is 48 hours, whereas the half-life of PCT is 24 hours. So probably, you know, prognostically speaking, this would be a better marker for active bacterial pneumonias, the PCT I'm talking about.
So it's a procalcitonin in a patient with sepsis, in a patient.
Bacterial sepsis.
Yeah, in a patient with bacterial sepsis.
Better.
We usually, as far as the prognostication is concerned, one would usually repeat it after 48 hours or day 0.
48 hours for CRP, probably procalcitonin levels to be repeated every 24 hours, because the half-life is just 20 to 24 hours.
Yeah, but the recommendations per se in the ICU is 48 to 72 hours if you want to
Even with the PCT?
PCT, sir.
So basically you want to see the trend. The idea, none of these tools are actually diagnostic or for any bacterial infection. There are various situations where even in a viral COVID patient also could have a very high procalcitonin levels because of the initial cytokine storm. Ultimately they are all markers of the inflammatory cascade.
Absolutely.
Nothing else. The only initial studies, if you see way back 10 years back, 15 years back, they all started with a lot of hype about procalcitonin being a diagnostic marker for any kind of bacterial infection in the body, especially chest infection. There were various studies. In fact, I myself had conducted a study when I was at Batra Hospital in 2007, where we had taken our 100 COPD patients. 50 of them were given a procalcitonin guided antibiotic therapy. That if PCD was positive, they were given antibiotics. The other 50 patients, COPD exacerbation patients, if PCD was negative, were not given an antibiotic. All of them did equally well, whether we used PCD as a marker or we didn't use PCD as a marker. But the advantage of using PCD was that you were able to reduce the antibiotic load by 72%. In the patient where you do a PCD is negative, you stop the antibiotic, the patient will have similar recovery as compared to somebody who's received the antibiotic for 7 days, 10 days as a usual course.
So, that's wonderful.
But over the years, unfortunately over the years, procalcitonin has really not stood the test of time and now is not used for diagnostic purposes but is used for prognostic purposes. So you do it on day 1 and then you see how the trend is. If the trend is increasing, that means your patient is not improving, that you need to do something else. If it is settling, then you can still be sure that yes, you are on right track.
So if it's increasing, probably would, you know, say that it's probably going into a septic condition.
Absolutely, or there is a source control.
And if it is decreasing, probably, you know, antibiotic is working. Great.
Check it after 72 hours and see.
Okay, 72 hours. I thought probably repeat it every day.
72 hours. It's a very costly test. So even internationally they got accepted.
Okay, I thought you repeat it every 24 hours in ICU. Anyway, let me proceed further and talk about, you know, recent studies suggesting the use of the FDG PET scan early in the workout of the PUO, which yields, you know, early and correct diagnosis in 6 to 80% of the people. So early, you know, FDG PET to be used early to, you know, diagnose whether you have a metastatic lesion or inflammatory lesion or infective lesion. Your words on the PET, on the FDG PET.
So, sir, early, I would not say as much because, you know, subjecting a patient upfront to a PET scan, you might not be able to justify that. But once you have done the first line of investigation, which is
the negative,
the blood works, the cultures, the echoes,
everything is okay.
Then it is absolutely reasonable to go ahead with the PET scan, and in most cases you do get an answer.
Right. So early use of FDG PET is probably recommended in diagnosis of PUO.
Amina.
Let me proceed further and talk about the vaccines.
Not recommended. Early
not recommended.
Not recommended.
So what he
Message is not recommended.
yeah. So I think what sir is also saying is that after 2 weeks, if you've done all the basic
If you've done all the
investigations
investigations and everything is negative, probably this is recommended. Okay. Usual pathogen is a streptococcus pneumoniae, but after you've had vaccinations today, it has become less now.
No, sir, not
It
yet.
does continue.
Not yet.
Yeah,
Not
it
yet.
does
In
continue.
At least in USA, it's becoming less because of the excessive vaccination. I don't know how far it is true in India.
Sir, even in the US it is becoming less common because of the extensive vaccination of PCV13 in the children, not in the adults as much.
Not in adults.
Not in adults as much, it hasn't picked up really still. We still have a long way to go. So now from PCV7 to 13 to now 15 and now PCV20 has also been launched.
I was
in
going
the
to talk
US.
about the A21 variant PCV, which was approved just about a month back, you know, in June 24.
So June 23 it has been launched.
June,
It's been a year now.
it was approved in June
Last year itself
24.
it was approved.
Okay. Okay. So to prevent invasive pneumococcal disease,
PCV20 has been approved for it in the US.
no,
We don't have that in India.
I'm talking about A21 variant. Which is
21.
approved just last month, sir. A21 variant, the PCV was approved just last month, 2024, for active vaccination to prevent invasive pneumococcal disease.
Sir, so
Just
when they
last
say,
month.
okay sir, let me correct you there sir. Sorry for that, but when they say invasive pneumococcal disease, it does not include pneumonia as such. Invasive pneumococcal disease is basically talking about streptococcal meningitis, pharyngitis, renal, osteomyelitis, all those kinds. This is, and bacteremia. So invasive pneumococcal, so there was this study which was conducted in Holland where they found, Netherlands basically, where they found that when they were using this PCV13 as a vaccine, there they were able to bring down the rate of CAP caused by pneumonia also. That is only one of the very few studies which have shown that chlamydia-acquired pneumonia also reduced, all cause pneumonia reduced when they were using PCV13.
So I'm talking about A21 variant.
PCV 821, so that's what I'm saying. That PCV 821 focuses on invasive pneumococcal disease.
This is what I said, sir.
Invasive pneumococcal disease does not necessarily mean pneumonia. Pneumonia may be with bacteremia or without bacteremia.
Absolutely.
So
Yes.
there PCV13 may or may not be helpful. So although we loosely call it the vaccine for pneumonia, it's the pneumococcal vaccine, not the vaccine for pneumonia.
Okay. Let me proceed further regarding the role of systemic steroids. Septic patients who are hypotensive, in spite of fluid and vasopressor support, stress dose steroids can be given to avoid delay in the treatment of presumed adrenal insufficiency and prevent ARDS. Your words on the steroids, the systemic steroids.
So we usually give them 200 mg of hydrocortisone over 24 hours. That is not to prevent ARDS, that is to prevent the septic shock. That's a treatment of the septic shock as an established modality.
And presumably, probably